A very respected chairs, a very respected organizers of this conference, presidents and secretaries. So this is my great pleasure to be here with you and to present my lecture about homocysteine as a biomarker of environmental health risk. And also, I will speak about the roles of homocysteine in cardiovascular pathophysiology and link with homocysteine-related vitamins. So first of all, I would like to say a few words about the history of the discovery of homocysteine, which was discovered in 1932 by two researchers, Butts and Davignon. Later, Davignon won the Nobel Prize in 1955 in chemistry, partly for his work on this project. And today we know that homocysteine belong to the group of so-called sulfur-containing amino acids, including methionine, cysteine, and taurine. So here you can see the photo of one of the greatest pioneer in the field of the homocysteine research, Professor Kilmer McCulley, who in 1969 described in American Journal of Pathology two cases of children patients with accelerated atherosclerosis and inborn hyperhomocysteinemia. So until the day, he was one of the greatest in this field. Here you can see how this is complex homocysteine metabolism. This is intermediate in the metabolism of amino acid methionine. So here you can see the first metabolic pathway, so-called transmethylation and remethylation with the roles of different vitamins of B group, including vitamin B6, B9, or folate, B12, and B2. During last time it was discovered too. And also you can see another metabolic pathway, so-called transsulfuration with the role of vitamin B6 too. Today, we consider that the normal values of total plasma homocysteine is up to 15 micromole per liter. However, in this total pool of homocysteine are included also different homocysteine metabolites like homocysteine thiolactone, free and bound homocysteine thiolactone, and other homocysteine substances which are very similar with homocysteine or which comes from homocysteine in different metabolic pathways. So here you can see that total pool of homocysteine consisted of free and protein-bound homocysteine and should be in reduced and oxidized form. Here you can see the imbalance in homocysteine metabolism, or so-called hyperhomocysteinemia. It means that concentration of homocysteine is more than 15 micromole per liter, although some researchers consider that values more than 12 micromole per liter should be also considered as hyperhomocysteinemia. And we see that there are effects on molecular level and there are effects on cellular level. And you can see here which kind of effects hyperhomocysteinemia induce. For example, epigenetic changes affect DNA or RNA methylation, as well as do homocysteine-relation of proteins induce oxidative stress, and so on, and also show the effects of general human health, considering different diseases, including cardiovascular and neurological diseases, where hyperhomocysteinemia should be found. So here you can see the role of epigenetic modification in one carbon metabolism. This is right part of this slide, where you can see DNA methylation, RNA methylation, and histone methylation. And today it is considered very important, and it was shown from the level of two intermediaries in methionine homocysteine metabolic pathway, so-called S-adenosyl methionine and S-adenosyl homocysteine, where methyl group should be transferred from methyl acceptor to methyl from methyl donor to methyl acceptor. Here we can see the role of hyperhomocysteinemia through one quite new schema given in Frontiers Cardiovascular Medicine. And we can see here the effects on inflammation, on oxidative stress, on apoptosis, and also we can see the connection with different gasotransmitters, including hydrogen sulfide in this slide. And here you can see that different diseases as well as environmental risk factors, including uncritical usage of drugs, then gender, and bad nutrition and bad lifestyle habits, genetics, age, and so on, should affect a homocysteine level and should induce hyperhomocysteinemia. And it's very interesting that homocysteine is a non-proteogenic amino acid. However, Professor Jakubowski from Poland, he described in 2019, he described 4 different ways how homocysteine from non-proteogenic amino acids should become proteogenic. And these processes included N-homocysteine-relation, S-homocysteine-relation, demethylation, and pure homocysteine-relation. However, homocysteine also should affect nitric oxide production and bioavailability. And you can see here that increased level of homocysteine decrease the activity of superoxide dismutase, increase production of different inflammatory products, as well as affect the balance between superoxide anion radical and nitric oxide, as well as increase vascular stiffness and decrease vasodilatation. And here you can see the production of hydrogen sulfide in this metabolic pathway of transsulfuration. And you can see on the different locations here in this schematic presentation the role of vitamin B6. In a simple way presented, you can see here the importance of vitamin B complex in homocysteine metabolism, including the role of folate and vitamin B12 in the process of remethylation, as well as the roles of vitamin B6 in the process of transsulfuration. However, for us, it is very important that homocysteine should increase superoxide anion production and should decrease nitric oxide production. And 4 different substances like tetrahydrobiopterin, methylene tetrahydrofolate, folic acid, and vitamin B6 should affect this balance. Also, during last time, it was recognized that vitamin B6 deficit should affect on homocysteine and hydrogen sulfide bioavailability. And you can see here the decrease vitamin B6 level should cause increased homocysteine level, should cause decreased hydrogen sulfide production, and also should affect sulfic hydration and affect inflammation and lipogenesis in different experimental models. So generally, we know a lot about the effects of folic acid and vitamin B6. However, here I want to underline a few very important effects of folic acid on cardiovascular system and especially on the vascular smooth muscle. So here you can see that active form of folate improves the action of nitric oxide synthase and affect nitric oxide synthesis, improves endothelial function in peripheral circulation, increase coronary vasodilatation, and slightly lowers arterial blood pressure in patients with coronary heart disease. And also, we found and published in 2007 that folic acid perfusion of the heart, of the isolated right heart, significantly increases the flow through the coronary circulation, reduces the production of superoxide anion radicals, and leads to the increase in the lipid peroxidation index. So here you can see the very known reciprocal relationship between increased homocysteine level as well as decreased plasma folate. And this is the reason that in different pathological conditions and clinical conditions that different kinds of vitamin B involved in homocysteine metabolism, like folate, like vitamin B6, and like vitamin B12, should be measured. However, there are different values from very representative labs, and today it's very difficult to say what are the normal values of the mentioned B vitamins. However, regarding the effects of vitamin B6, which is involved in more than 140 biochemical reactions in human body. So regarding the effects of oxidative stress show and the mild antioxidative effects. Also, there is inverse relationship between the concentration of vitamin B6 in plasma and the risk of myocardial infarction, as well as there is an inverse relationship between vitamin B6 intake and coronary heart disease. Also, today it is known that vitamin B6 show anti-inflammatory action. So that was the reason that we tried to show the effects of different applications, different model of applications of folic acid and vitamin B6 alone or together in 4 different experimental models: a model of monocrotaline-induced heart failure, then model of streptozotocin-induced diabetes mellitus, model of hyperhomocysteinemia, and model of isoprenaline-induced myocardial injury. Everything that in rats, and to see which are differences and which are the effects on oxidative stress, on cardiometabolic parameters, on histomorphometric changes on rat cardiac and aorta tissue, as well as to see the involvement of different gasotransmitters, including nitric oxide, hydrogen sulfide, carbon monoxide, and so on. So here you can see, firstly, the proof of monocrotaline-induced heart failure in rats. These are the results obtained by echosonography in rats, and you can see here different parameters which confirm that monocrotaline-induced heart failure. This is also confirmed using histomorphometrical methods. You will see that later. And first of all, you can see here how folic acid affects cardiometabolic, oxidative stress, and immunohistochemical parameters in this model of rat heart failure. So I have to mention that monocrotaline-induced rat heart failure, and the other models are for the left ventricular heart failure in rats. And you can see here we tried three very important cardiometabolic biomarkers like homocysteine, like high-specific troponin T, and like activity of von Willebrand factor as a parameter for endothelial function. So you can see here that in the experimental group where after monocrotaline folic acid were applied, so you can see dramatic differences in these cardiometabolic biomarkers. And if you see this slide, you will realize that we evaluated the activity of superoxide dismutase, glutathione peroxidase activity, the amount of thiol, sulfihydryl groups in red cardiac tissue, as well as glutathione content and the content of reactive carbonyl derivatives. And we found very, very mild effects, very mild antioxidative effects of folic acid in this model. However, here you can see the effect of application of folic acid on histomorphometric parameters of the right heart, as well as on the Ki-67, which is one of the immunohistochemical parameter here. And you can see also that there is only an effect on this parameter of proliferation, which is dramatically decreased if you compare it with monocrotaline. So here you can see the influence of subchronic co-application of vitamins B6 and folic acid on cardiac oxidative stress and biochemical markers in monocrotaline-induced heart failure in male visceral albino rats, also with three very important cardiometabolic biomarkers as previously shown. And also you can see that there was no difference in homocysteine level. However, there was a difference in high-specific troponin T, as well as a decreased level of von Willebrand factor activity. So it means that this co-treatment with both vitamins, vitamin B6 and vitamin B9, also possess some kind of positive cardiometabolic activity, and also the activity of superoxide dismutase, glutathione content, activity of glutathione peroxidase, as well as amount of thiol groups, the content of reactive carbonyl derivatives, and here also the nitrotyrosine content were measured in this group of experiments, and also it was found a very mild effect of this joint application of both important vitamins in homocysteine metabolism. However, here you can see histomorphometric parameters of a rat heart, which confirm the previous findings. And if you use, for example, alone vitamin B6 in this model, there are no, or there are also very mild effects in this experimental model. So generally, we did not find so impressive beneficial effects of especially vitamin B6, but we found beneficial effects of folic acid. However, in experimental model of diabetes mellitus, we found that we found a very important hypoglycemic effects of applied folic acid in streptozotocin-induced diabetes mellitus. As you can see here, this is the confirmation of the streptozotocin-induced diabetes. And here you can see also the positive effects on homocysteine level, on alpha amylase activity, negative effects on fibrinogen level, as well as positive effects on von Willebrand factor activity. However, here you can see two adverse effects of folic acid administration in streptozotocin-induced diabetes mellitus, including dramatically increase of serum urea and dramatically increase of serum creatinine. And in the experimental model of hyperhomocysteinemia, and after 4 weeks of treadmill or aerobic exercise or application of both substances, vitamin B6 and folic acid, you can see here, if you compare with the hyperhomocysteinemic group, there is a decrease of the level of homocysteine. There is a decrease of LDL cholesterol level, and also there is a decrease of paradoxically vitamin B12. And histomorphometric analysis of red heart shown that, for example, at the same time, application of physical activity as well as hyperhomocysteinemia dramatically made worse finding on the histomorphometric parameters, increasing the thickness of Red's left ventricle, right ventricle wall, then intraventricular septum, as well as increased transverse diameter of the red hearts. And you can see here, also here, one very interesting finding. Then practically in the group where hyperhomocysteinemia and physical activity was applied, one atherosclerosis plaque was appeared, and this is not typical for the rat and should give an insight or idea for a new experimental models for the testing of atherosclerosis in rats. Finally, we tested the effects of folic acid and vitamin B6 on the experimental model of isoprenaline in myocardial injury in rats. Unfortunately, I have no the results of vitamin B6 here to show you in this model. However, we found, for example, with pre-treatment with folic acid, which was given intraperitoneally or orally, we found practically, nevertheless, of the used way of application, we found a decrease of homocysteine level in this model, which is very interesting. And also we found that there is parallel increase or decrease after folic acid administration of two cardiometabolic markers and markers of myocardial injury, homocysteine as well as high-specific troponin E. You can see here, and this is only in this model found, I will show you later, and you can see that practically after application of folic acid intraperitoneally or orally, there is there are decrease of the value of homocysteine or high-specific troponin E. You can see here, if you analyze and if you compare different cardiac injury biomarkers, including high-specific troponin T or E, LDH, then aspartate aminotransferase or alanine transferase. So you can see that only in isoprenaline-induced myocardial injury, there is a comparison, positive comparison with homocysteine. And here you can see this very interesting that isoprenaline administration increase heart rate and increase myocardial oxygen consumption, leading to myocardial injury and myocardial infarction, and lead to increased homocysteine level. With earlier conferred effects in our experiments that we found pro-arrhythmogenic effects of folic acid as well as different types of results. You can see here that this is very interesting for the new research and new evaluation, and taking into consideration this parallel increase of homocysteine as well as high-specific troponins in this model. Here you can see a few publications we produced during last time, including the effects of folic acid and leucovorin, folinic acid, which have a potential to prevent SARS-CoV-2 virus internalization with the group from Banja Luka. And you can see the effects of aerobic treadmill training as well as the effects of folic acid on isoprenaline-induced myocardial injury in rats. So generally, I can say that homocysteine has an important physiological role in metabolism. It stores sulfur molecule and transfers the methyl group. Itself, it is toxic, but thiolactone metabolites are very toxic. They interact with other molecules in the body, including proteins, lipid molecules, and so on. So although micronutrients deficit in vitamins B6, folic acid, and B12 lead to hyperhomocysteinemia, administration of both mentioned vitamins have shown mild favorable cardioprotective effects in different experimental cardiometabolic models in rats. However, I can conclude here that homocysteine could be a biomarker of environmental health risk, including the effects of nutrition, drugs, toxins, and so on, including cardiovascular risk. And for example, in animal hyperhomocysteinemia models, there are altered epigenetic marks, decrease SAM-SAH ratio, decrease DNA and RNA, and histone methylation. So this is the very important for the future research. And of course, I have to express a gratitude to the many collaborators with whom I work on this full model, as well as on the translational model in clinical research. You can see here, and also I have to express gratitude to the agencies and governmental fundings and European Union fundings and faculties in Belgrade and Banja Luka who supported this type of research. Thank you very much for your attention.